Good afternoon. With this, we start the oral presentation. And I take this pleasure to invite our esteemed chairperson, Professor Sangeeta Yadav. Madam. Madam is a professor and head of the department in the Department of Pediatrics, Hamdard Institute of Medical Science and Research, New Delhi, India. Her area of interests are growth, puberty, obesity, and metabolism. And our second chairperson, Dr. Mahesh Maheshwari, is a professor pediatrics in charge Pediatric Endocrinology Division in AIIMS Bhopal. And sir, area of interest are growth and type 1 TM. Over to you, sir.
Good morning. Welcome back for our this mixed bag of session related to the oral presentations, the research work done by many of our young colleagues who will be presenting over here. And without much ado, we'll move on with the first presentation, and which is going to be done by your name, the last name, Kashimada. He is going to make the presentation on one-step PCR using long read sequence is useful for the early diagnosis of non-classical CH.
Okay. Hello, my name is Kenichi Kashimada from Tokyo. And unfortunately, Adachi Erika Adachi cannot be here because of her health conditions. So on behalf of her, I will talk about this talk. And as you know, 21 hydroxylase deficiency, 21 OHD, is caused by loss of function of CYP21A2 gene mutation. And the one of the characteristic of this gene is the true gene and pseudo gene is located in the same locus tandemly. And the severity of this disease is related with the genotype, that is the residual enzyme activity. And according to the severity, the disease can be classified into three groups, that is salt wasting type, symphorizing type, and the mildest non-classical type. And today's my talk is about the non-classical type. And the non-classical type, the background of the non-classical type in Japan is it is quite rare, and the P31L mutation is the most common. And on the other hand, considering the genetic variation of 21 OHD, there are the two major variations due to the extremely homology between the pseudo gene and the true gene. And that is, first one is the chimera gene. That is a kind of caused by the cross recombination between the identical sequences and removed 30 kilobases of the sequence between the pseudo gene and the true gene, making a chimera gene. And the second one is microconversion. That is, the mutation is come from the pseudo gene. And so, according to regarding the genotype of NC type, there are the three major variations. The first one is a 5 missense variants, that is the P31L and other type of missense variants. The second one is promoter variants, so it caused by the pseudo gene and reduce the transcriptional activity. And the third one is chimeric gene. There are 10 types of chimeric genes, but the CH4 is the only chimeric gene that will cause NC type. And other types of the chimeric gene will cause classical type of CAH. And considering the genetic analysis of this gene, this homology will make troubles. And conventional method, that is the PCR and Sanger or next generation sequencing, is not appropriate for this gene analysis. And recently, long-read sequence technique is developed. It's quite suitable for the analysis of this gene. That is, in using this technique, we can read more than 20 kilobases in a single assay. So it will give us the allele specificity of the information of the allele specificity, and we can identify the structure abnormalities such as chimera and the deletions. and also covering the region surrounding the target gene. So it's quite nice technique. And recently, we established a very brief and straightforward method to analyze CYP21A2 gene using this technology. So we designed one set of primers. The forward is red one, so here and here. It's quite identical sequence, and the reverse one is here. So for identifying the chimeric gene, and it will work. And for the microconversion, it will work. And we can get 8 kilobases of PCR product and conducting the long-read sequence analysis. And recently, we reported that for classical type of CAH, this system worked very well and satisfactory. So we identified a novel missense variant and chimeric junction. So how about NC type? So LRS system will give us a deep insight about NC type, genotypes of NC types. And we analyzed our cohort of non-classical type. The N is 10. And the results were like this. So you can see that the right round graph. And one thing we noticed is that the prevalence of P31L, it was much less than the expected, as we expected. So where is the missing P31L patients? The answer is here, CH4. Because the chimeric junction of CH4 is located in exon 1 to exon 2. And the P31L is the only variant which is harbored by CH4. So it is quite difficult to differentiate P31L and CH4 using conventional method. So previous report, using conventional analysis, we report our cohort like this. So the prevalence of P31L using conventional method is quite consistent with the previous reports. So the second question is, do we need to differentiate to these genotypes, so CH4 and P31L? The answer is yes, because the promoter region of CH4 is come from pseudogene, so that promoter activity is reduced, impaired. On the other hand, the promoter region of P31L is maintained, so that the residual enzymatic activity should be different. Indeed, the CH4 phenotype showed severer than that of usual NC type of CAH. So we checked the severity of CH4 using a 17-OHP in our cohort. As you can see, CH4, the 17-OHP levels of CH4 is much more than P31L. And we can put the reference data, and also the CH4 is more than the non-classical type. Also, we experienced siblings of cases, and especially the left case is a sister, and she showed a normal female genitalia, but she showed poor weight gain, body weight gain, and we administered hydrocortisone during the first year of her life. Also, the two cases showed a very extremely advanced bone age. So we think that CH4, the severity of CH4 could be between the SV and NC type. This is my first message. And the second message is that the prevalence of P31L is previous reports, but we don't believe anymore this. Our data suggests that CH4 and P31L is identical and from 30 to 35%. So thank you for your attention.
Thank you for that lovely insight into this genetic analysis of non-classical 25-hydroxylase deficiency. Definitely, it is given told us how clinically and otherwise the outcome is better for this genotype-phenotype presentation. It is open for comments and questions from the house.
Thank you, Kenichi.
Yeah.
That was a lovely talk.
Yeah, thank you.
A really interesting approach. Can you tell me two short questions? Firstly, what is the cost of this compared to normal PCR or Sanger sequencing? And maybe answer that first.
Yeah. You used a kind of library systems, so cost is quite less, and comparative to the conventional method, even less. So it's quite nice.
Okay. And accessing your population, because you've got to identify them to do the sequencing. How are you identifying the patients?
And chronologically, and firstly, most patients were identified by newborn screening, but some patients were identified precocious puberty, and those patients were diagnosed endocrinologically, not genetically. And then we collected the samples and analyzed and got the results.
Right. Okay. Thank you.
Yeah.
Okay.
Hi, Ken. Thank you very much
Thank
for
you.
your good, nice presentation. I'm wondering. I'm wondering.
And then we
just
will close after. Right.
sorry.
Go ahead, Dr. Rico.
Okay. CH4 patients should be classified as non-classic or not non-classic.
I think it's difficult, but because according to the guideline, especially male patients with NC type are not necessary to be treated. So hydrocortisone treatment is basically not necessary. But I think some cases with CH4 variation require HDC treatment. So considering those facts, I think that maybe we cannot say this is simple virizing form because the heart genitalia was completely female phenotype. But maybe a kind of simple virizing form, and we can consider always look at the treatment of these patients.
Yeah, it's actually just 1 minute. Actually, it is basically your clinically how they are responding. No, so the ones which will be on CH4 would be their response would be a little different rather than the ones which are on the other side. No, with that. So there will be some variation in the response to the treatment also. And overall,
as you said, some variations of responses to the hydrocortisone treatment. So we should adjust for each patient. But the responses themselves are not too bad.
okay.
Yeah,
Any enzyme studies?
yeah.
Any enzyme studies on these patients?
This is the last
CH4.
question.
CH4, actually not, because the enzyme activity would be the identical of P31L. So we don't think it's necessary.
So good morning, everyone. So the next presentation is on a virtual mode. Dr. Wen Yong from China is going to talk on development and validation of central precocious puberty, diagnostic prediction models in girls based on machine learning program. So welcome, Dr. Wen Yong. You can start your presentation.
Diagnostic prediction models in girls based on machine learning algorithm. I report my content in these 3 parts. The first part is background and objective. We know that the precocious puberty is classically defined by the appearance of sexual secondary characteristics before the age of 8 years in girls and 9 years in boys. However, after a national cross-sectional community-based health survey was performed, the diagnostic cut-off point of precocious puberty girls was adjusted from 8 years to 7.5 years in China. Premature activation of the HPG axis leads to central precocious puberty, the most common type of precocious puberty, which is associated with a lower final adult height and increased rate of psychological disturbance. The diagnosis of central precocious puberty is dependent on the timing of sexual characteristics, symptoms, fecal and laboratory results. Among them, growth-hormone-releasing hormone stimulation test is important in the discrimination. To identify the peak level of luteinizing hormone and follicle-stimulating hormone, multiple blood samples must be taken, which can be inconvenient and time-consuming. How to diagnose CPP without relying on GnRH stimulation test has become a clinical research purpose in the field of endocrinology in pediatrics. Prediction model can be used to predict the probability of CPP diagnosis based on some baseline features of patients. Some researchers have developed several prediction models based on different measures. These prediction models provide an exploration of identification tools for CPP patients. However, the prediction models have not yet entered the clinical application. Due to the adjustment of diagnostic criteria for the CPP in Chinese girls, the applicability of the previous prediction models to the current diagnosis is questionable. Since previous study did not provide specific means of using past measures, this study aimed to develop a new diagnostic prediction models for CPP diagnosis in girls based on machine learning. The second part is measures and results. This was a retrospective observational study. The medical records of 1,310 girls with PP from January 2014 to June 2023 in our hospital were collected. The participants included 502 girls with CPP and 808 girls with non-CPP. All participants were randomly divided into 3 groups: the training group, validation group, and test group. The training group was used for model development, the validation group was used for model parameter adjustment, and the test group was used for external validation of the model. Model development involved the following steps. The first is candidate predictors transformation. Second is predictor screening. And the third is model fit. And the last step is the external validation and the model comparison. In the first step, a total of 12 independent predictors were initially included, including age, disease cause, height SDS, BMI, current stage of breast development, current stage of public health development, basal LH, basal FSH, bone age minus age, height SDS for bone age, uterine volume, and larger ovarian volume. As shown in the table, some of the predictors make the necessary transformations based on their data distribution. The candidate predictors above were further screened by the through regression based on one standard error criteria of lambda. A total of 8 independent predictors were screened, including age, disease cause, height SDS, basal LH, bone age minus age, height SDS for bone age, uterine volume, and larger ovarian volume. With these predictors, prediction models were developed with 5 different measures, including logistic regression, SVM, random forest, XGBoost, and fully connect neural network. The internal and external validation showed that the S3M model performed best among the 5 models. The final part is the conclusions. The first is that this study developed prediction models based on machine learning algorithms for the diagnosis of CP girls. And the second is the international and external validation ensured a good degree of discrimination and calibration of the models, which could assist the diagnosis of CPP under the condition of basic clinical information. Thank you to my team members for their work on this study, and thank you very much for listening.
Thank you. Thank you, Dr. Wenyong, for I think you will be available online. Yeah. Thank you, Dr. Wenyong, for a nice presentation. I think before opening the questions for the audience, I just wanted to know what method you use to for the data accuracy and data cleaning, especially when you use the retrospective studies for making this model. I am audible?
Oh, yes, I'm online. Okay, can you hear me?
Yeah. Now I am audible?
Oh, yes.
Yeah.
Of course, because of it is an operation study, there still have so many limitations here, and that can and absolutely the research data is from the single center, so the performance must be intact and must be external validation in some hospitals. And at present we have contacted some 3 large hospitals in different regions in China to cooperate with the external validation of the model, and which will be great helpful for the improvement of the model. Thank you.
Thank you. Any questions from the audience? Yeah.
Sorry, Paul Hoffman here, New Zealand. Your model detects central precocious puberty, but one of the issues is making sure you don't miss peripheral precocious puberty. Does your model allow you to identify those with peripheral precocious puberty as, or at least identify them as a risk for those using your model?
No, we just distinguish the central precocious puberty and particular puberty, precocious puberty. And this study does not enter the precocious puberty, the PVP.
I think initially that's what you must have embarked on. Just do the central precocious puberty and its validation, and then perhaps move on with the peripheral, and once one part is done. Thank you so much, Dr. Wenyong. Now, I think we have to move on to the next. Any other questions? Okay, we move on to the next presentation. Thank you very much.
Thank you.
Now, the next presentation is once again a virtual presentation by Dr. Sharmeen Mehbooba from Bangladesh. It is going to be on variable endocrine presentation in children with partial trisomy 9q and experience from a tertiary care hospital in Bangladesh. Over to you, Dr. Sharmeen.
Hello, am I audible?
Perfect, go ahead.
Okay, thank you. Sorry for the interruption. Can you see my slides?
Visible. Go ahead. They
Okay.
need to be put
Thank
into
you.
the slideshow.
Yes, of course. Hello, greetings from Bangladesh. I am Dr. Sharmin Mahuba, and thank you, APES and ISPI, for giving me the floor. Today, I am going to talk on variable endocrine presentation of children with partial trisomy 9q and experience of tertiary care hospital in Bangladesh. You know, complete and partial trisomy 9 is the fourth common chromosomal disorder with over 150 reported cases in literature, and it accounts for 2.7% of all trisomy. It is of two types, partial trisomy 9p and q, and the patient with partial trisomy 9q has more chances to survive. The clinical signs and symptoms of children with this genetic disorder vary depending on the size and location of the duplicated segment. And there are variable anatomical defects reported. The reported endocrine problems are growth hormone deficiency, short stature with Turner-like features, cryptorchidism, disorder of sex development, delayed puberty, delayed bone age, and hypothyroidism. So the objective of this study was to find out the variable endocrine presentation in children with partial trisomy 9q attending the pediatric endocrine outpatient department of BSMMU. It was a prospective observational study which was done from 1st October 2021 to 31st March 2024. And total 13 children having partial trisomy 9q detected by karyotyping were included in this study. The chromosomal analysis was performed by peripheral blood lymphocyte culture, and appropriate biochemical and hormone analysis was done. Ultrasonogram of whole abdomen was especially done in case of children with DSD. We all know what is DSD, short stature, delayed puberty, and Turner syndrome, and so I'm going to skip. The congenital adrenal hyperplasia was diagnosed in this study by doing the rapid ACTH stimulation test, and when the children having hyponatremia and hyperkalemia was classified as salt wasting variety, and the patient having only the feature of androgen excess was diagnosed as having simple virilizing form. The data analysis was performed by SPSS version 23. Now the result. Total number of children having partial trisomy 9q were 13, and out of 13 children, 12 were reared as female and only one child was reared as male. The mean age at diagnosis was 7.3 plus minus 5.2 years, having the age range from 15 days to 14 years. Here we can see the distribution of the patients according to the endocrine presentations, and the majority presented with DSD, followed by short stature, then delayed puberty, and only one child had obesity. Here is the details of the children with partial trisomy 9q and DSD. And out of 11 patients presented with DSD, 4 presented with clitoromegaly. All of them were the children of non-consanguineous parents, and 2 of them had separate urethral and vaginal orifice, and 2 of them had a single orifice through which urine passed. And only one child presented at 15 days of age, so too early, but others presented later. And here we can see the clitoromegaly. Rapid ACTH stimulation test was done in all patients to exclude congenital adrenal hyperplasia, and only one child, this one, was diagnosed of having simple virilizing form of CH along with the duplication of chromosome 9. Here is the karyotyping, and here we can see the defect in chromosome 9. Then 2 patients having normal female genitalia, one presented at 9 years and 7 months, another one at 11 years of age, both of them having the features of Turner syndrome, short stature, and one of them have had obesity, and the ultrasonogram and other investigation are also suggestive of having a Turner syndrome. And here is the karyotyping, 45XO and 46XX with duplication of chromosome 9. Here are the 2 children with features of Turner syndrome, and we can see the webbing of neck, the wide carrying angle, and also the low hairline. And this child had obesity, and we can see the acanthosis nigricans. I have put the pictures with the permission of the guardians for your kind information. And here is the karyotyping report of one of those children. And here we can see that 45 another X chromosome is missing, and there is a defect in also in the chromosome 9. Another 2 children having normal female genitalia one of them both presented with short stature, and one of them had delayed puberty, and another one had the lymphedema of the right lower limb. And unfortunately, ultrasonogram revealed absence of uterus and both fallopian tubes in both children. And here we can see the karyotyping report of one of those children. Out of 11, 3 had karyotyping 46XY with duplication of chromosome 9, and one of them was diagnosed of having the salt-busting variety of congenital adrenal hyperplasia along with the duplication of the chromosome 9, and the child presented with hyperpigmented genitalia and bifid scrotum, presence of gonad in the both inguinal region, and there was hypospadias. And this is the only child having the 46XY with duplication of chromosome 9 who was reared as male, having the both gonads in the labioscrotal folds, micropenis, and the urethral opening was at the tip. I have already mentioned these that out of 11, 5 had clitoromegaly, 4 with micropenis, 2 presented with features of Turner syndrome, and 2 with normal female genitalia with absence of uterus and ovary. And here we can see the karyotyping of those children. The majority had 46XX followed by 46XY and then 45XO with duplication of chromosome 9. Here is the distribution of the patient according to the presence of other endocrine disorders. In short, those who presented with short stature, and the number was 7. The majority had DSD, 5 in number, then followed by delayed puberty, then features of Turner syndrome, and only 1 case with obesity. And here we can see the details of the 3 children who presented with delayed puberty. All of them presented at 14 years of age, and all of them had short stature. One of them had features of hypopituitarism and also had hypogonadotropic hypogonadism. And another child, I have previously shown that ultrasonogram found absence of uterus and both fallopian tube. So in conclusion, the common endocrine presentation of children with partial trisomy 9q are DSD, short stature, and delayed puberty. And there is variable presentation of DSD like clitoromegaly, micropenis, features of Turner syndrome, and normal female genitalia with absence of uterus and ovary. And the majority had 46XX followed by XY, and then 45XO and 46XX with duplication of the chromosome 9 karyotype. The short stature presented, children with short stature also presented with DSD, delayed puberty, mosaic Turner, and obesity. So the key message is children with chromosomal disorders have variable endocrine presentations. Therefore, karyotyping should be considered in endocrine patients to find out these rare conditions. Thank you all, and thank you for your patient hearing.
Thank you very much, Dr. Sharmeen. Interesting analysis. And since these children had come a little late, so what about their management and final outcome as far as their stature is concerned and their addressing their replacement therapy?
Thank you very much. I have shown that the DSD cases, 4 presented with clitoromegaly, and we are consulting with the pediatric surgeons, and at the appropriate time clitoroplasty is our thinking, but and also in 2 cases vaginoplasty is needed. And regarding the child with children with delayed puberty, one having the features of panhypopituitarism, and growth hormone stimulation test is also done, having growth hormone deficiency, and also the hypogonadotropic hypogonadism. We're planning for replacement therapy at the appropriate time. And regarding
Yes, definitely, there will be a outcome is likely to be a little compromised for these children because they have come in a little late for their adulthood.
Yes, yes, of course, and it is our limitation in our country.
Okay. Any other questions or comments?
In the light of your study, do you recommend karyotyping in every case of CH?
Sorry, did you ask that whether we do the karyotyping in every CH?
Yes.
Yes, when there is ambiguity or atypical genitalia, we do the karyotyping. But if a male CH having gonads, presence with salt-wasting features, then sometimes sometimes not. We don't do the karyotyping usually.
Okay. Thank you very much, Madam Dr. Sharmeen, for that interesting study, the case scenarios which you had presented, which collected over a period of time. Now we move on to the next presentation.
Thank you very much.
Thank you.
So the next presentation is by Dr. Kanupriya Kundu. She is going to talk on diagnostic utility of serum inhibin B and AMH in 46XY disorder of DSD.
So good afternoon, everyone. So the title of my study is Diagnostic Utility of Serum Anti-Mullerian Hormone and Inhibin B in Children with 46XY Disorders of Sex Development. So DSD are the congenital conditions in which the development of chromosomal, gonadal or anatomic sex is atypical and which can be further classified based on the karyotype. So 46XY DSD can be classified as disorders of gonadal development or testosterone synthesis or disorders of testosterone action. Typical endocrinological assessment for 46XY DSD patients involves measurement of testosterone, androstenedione, and dihydrotestosterone following HCG stimulation. This aids in assessing testicular function and potentially diagnosing the underlying etiology. But the HCG stimulation test is cumbersome and time consuming and also requires multiple HCG injections over a period of 3 days followed by subsequent blood sampling. So testes secrete two another hormones, one of which is anti-Mullerian hormone, which is secreted in high amounts throughout the childhood when basal levels of testosterone and gonadotropins have little clinical use. This makes AMH an appealing biomarker for pediatric endocrinologists because no prior HCG stimulation testing is required. Similarly, inhibin B is also secreted in large amounts by the testes throughout the childhood and is another useful marker to check for testicular function. So through this study, we'll be able to determine the diagnostic utility of these two hormones in evaluating children with 46XY DSD and their role in assessing the etiology of DSD. So the research question was, what is the diagnostic utility of inhibin B and AMH in classifying patients with 46XY DSD? Which group of patients with 46XY DSD would benefit from additional testing with HCG stimulation? And what is the sensitivity and specificity of inhibin B and AMH in predicting the testicular function in these patients? So the primary objective was to assess the sensitivity and specificity of inhibin B and AMH in patients with 46XY DSD with respect to the standard test for testicular function assessment, which includes a combination of HCG stimulation test, imaging, laparoscopy, and gonadal biopsies. Secondary objective was to evaluate the diagnostic utility of inhibin B and AMH for testicular function assessment and to assess whether inhibin B and AMH can differentiate between different etiologies of 46XY DSD. So it was a cross-sectional observational study done over a 2-year period from July 2022 to June 2024 at Department of Pediatrics at All India Institute of Medical Sciences, New Delhi, after obtaining an institute's ethical clearance and written informed consent from parents or guardians. So cases of 46XY-DHD who presented with ambiguous external genitalia with an external masculinization score less than equal to 9 from 15 days of life to 15 years of life were enrolled. And but the patients who have been initiated in hormonal therapy or who have undergone gonadectomy were excluded from the study. So initially 36 patients were screened, and after getting a relevant history, clinical examination and assessment for as per inclusion exclusion criteria, 3 patients had to be excluded because they had an EMS score of more than 9, and 33 patients were finally enrolled in the study. All these patients underwent baseline hormonal evaluation in the form of testosterone, DHT, androstenedione, as well as baseline AMH and inhibin B. And out of this 33 patients, 2 patients were less than 3 months of age in the period of mini-puberty, hence HCG stimulation test was not done, and rest of 31 patients underwent a HCG stimulation test prospectively. So these are the reference age-based inhibin B and AMH cutoffs we have taken from the previously published data. So in this study, data was further analyzed using STATA version 17. Appropriate tests were applied, and a p-value of less than 0.05 was considered statistically significant. So the baseline characteristics are as follows. The median age in the study cohort was 3.6 years. Out of this 33 patients, 30 patients were initially reared as males, and rest of the 3 patients were initially reared as females. History of consanguinity was present in only 2 patients. The 20 patients had normal birth weight. Low birth weight was found in 9 patients and was not known in 4 patients. 19 patients had normal weight, 11 were underweight and 3 were overweight. 26 had normal height, 2 were moderately stunted, and 5 patients were severely stunted. And the mean external masculinization score was 4.1 plus minus 1.8 standard deviation. So etiology of this 46XY-DHD study cohort was that in out of 33 patients, 17 patients had androgen action defect, which included pile for reductase deficiency as well as partial androgen insensitivity syndrome. 9 patients had testosterone biosynthesis defect, and 7 patients had gonadal dysgenesis. And hormonal analysis was further done, and the patients were divided into 2 groups based on the testosterone response after HCG stimulation or no response. So out of this 33 patients, 31 patients underwent HCG stimulation test, out of which 13 had a testosterone response, and no response were obtained in 18 patients. And 2 patients who were in the period of mini-puberty had normal testosterone levels, so they are included in the responders group. So AMH levels in the 2 groups were 160 and 73 nanogram per ml respectively, and the difference was statistically significant. Similarly, inhibin B values in the 2 groups were 117 versus 43.4 picogram per ml, and the difference was statistically significant. Further, the results were further compared with the gold standard. So the sensitivity and sensitivity of AMH and inhibin B for assessing the normal testicular function were 94.1% and 82.4% respectively, and the combined sensitivity was 93.3%, but the specificity of both these hormones were 50% individually as well as 57% in combination. Receiver operator curves were further made for these 2 hormones. Area under the curve for AMH was 0.8. The optimum cutoff obtained was 146 nanogram per ml. And similarly for inhibin B, area under the curve was 0.77 with an optimum cutoff of 76 picogram per ml. Positive and negative predictive values were also calculated. So positive predictive value for AMH and inhibin B both were around 65%, and combined was also around 67%. But the negative predictive values of AMH was 89%, inhibin was 73%, and combined negative predictive value was around 88%. And also we observed that in patients, low levels of both AMH and inhibin B could predict a absent testosterone response in 86% of the patients. Results were further interpreted based on the various etiological groups. So these are the AMH and inhibin B values in 3 subgroups. Results were further analyzed by dividing the patients into whether they are gonadal dysgenesis or other diagnosis. So the AMH and inhibin B values in these 2 groups were statistically significant difference was found between these 2 groups. So finally concluding, so both AMH and inhibin B in isolation as well as in combination have high sensitivity and hence can be used as initial tests for assessment of testicular function in patients with 46XY-DHD. But keeping in mind the high sensitivity but low specificity of these tests, it increases the chances of providing false positive results, hence necessitating the need for further testing in the form of an HCG stimulation test to confirm the presence of testicular function.
But as we have already seen that low levels of AMH and NMB predicted low testosterone response in 86% of patients. Hence, in individuals who had both low and AMH and NMB levels can skip HCG stimulation test. And also these hormones can reliably differentiate between various etiologies of XY-DSD, especially in the setting of gonadal dysgenesis. Thank you.
Thank you, Kanupriya. Before opening the comment, I think it's a nice study. What do you think about the age-related variability that will that affect your interpretation of the results, which what you're saying?
Sir, actually, we interpreted the results on the age-based values also, although I haven't shown it here. But the final results which we have combined, it was also discussed as per the etiological groups mainly. But yeah, it will affect also. The age-based variability will also affect.
Sensitivity and specificity has gone down. What is the conditions that you think that is the reason why this is not up to the mark? What you expected?
Exact.
Hi, thank you very much for a very nice talk. My question, plus, or it's a comment as well as a question. Your data to me suggests that AMH, if you're going to do a test, AMH needs to be slightly better in terms of positive predictive value, in terms of its sensitivity, its specificity, and adding in beta inhibin does not help. The one negative about AMH, of course, that goes down with this high testosterone levels, but that's not an issue here. Would you agree with that? Would you agree that if you're going to do one test, then AMH level would be the one to do?
So the results when we combined both these hormones were not much different. As we see, the sensitivity was high for both these hormones, so it was for individually also, individually also, and when we combined the results, there was not much difference. Similarly, for negative predictive value also, the results were not much different when we combine. So maybe in individual also we can do, if one is available and the other is not available, then it can also suffice.
We move on to the next presentation, evaluation of lytic cell activity using single-dose HCG stimulation test in prepubertal children suspected of having hypogonadism, experience from a tertiary institution. Over to Dr. Ramya for the presentation.
Good afternoon all. Myself Ramya. I've recently completed my fellowship from Indira Gandhi Institute of Child Health, and my topic for today's discussion is evaluation of lytic cell activity using single-dose HCG stimulation test in prepubertal children suspected of hypogonadism. So the background being, during childhood period, the basal gonadal steroids are usually barely detectable because of the quiescent nature of the HPG axis. So here comes the role of stimulation test. So here what is already known with respect to HCG stimulation test is various protocols like single dose, multiple dose have been in practice, and very few Indian literature studies are there. So our study adds on to the usefulness of single dose HCG stimulation test in evaluating the hypogonadism. So the primary outcome studied is to assess the testosterone response and the magnitude of increase in testosterone level following a single dose HCG stimulation test among children with suspected hypogonadism. And the secondary outcome is to assess the age-based testosterone response and also to compare single dose versus multi-dose among those children who had a poor response to the former test. So methodology, we basically did a retrospective analysis of the case records over a period of 5 years from 2019 to 23, with inclusion criteria being included pre-pubertal boys aged 6 months to 18 years of age with features of undervirilization who were assessed by single-dose HCG stimulation test. And the exclusion criteria were patients with previous use of HCG or testosterone, genital surgeries, or with high basal testosterone levels. So of this, 127 met the inclusion criteria, and with 3 excluded and incomplete data of 21, the final study participants analyzed were 103. As a part of a unit protocol, we used to do a single-dose HCG stimulation test in the initial evaluation, and in case if there is a poor response to it, we usually go ahead with a 3-day. So here we analyzed that 84 cases had an adequate response to single dose. However, 19 cases had a suboptimal response. So the analysis of these 19 cases with 3-day HCG test showed that still a majority of the cases had a suboptimal response to 3-day as usual. So, few words about HCG. It's a glycopeptide with two formulations being available. One is a extracted form, and the other is a recombinant form. And as already told, there are multiple protocols, and even the definition of the appropriate testosterone response to the HCG stimulation varies widely, and this depends on the regimen and even on the age of the child. So, the testosterone in general rises by 2 to 10 times, or even maximum 20 times during infancy, and 5 to 10 times in childhood. However, there are a lot of studies which are given at discrete testosterone values, and one among them is a study by Ishii et al., where he assigned a cutoff testosterone level of 1.1 nanogram per ml, which predicted the Leydig cell activity during the pubertal period. So, with this cutoff, 110 nanogram per deciliter was the cutoff we used to delineate the adequacy of the response. So, the dosage we use 1500 international units for less than 2 years and 5000 international units for more than 2 years old. It is a single IM administration. Baseline is done, and the stimulated one is done 72 hours post injection. And DHT and androstenedione was also analyzed in suspected XY-DST cases. Whereas multi-dose, it is a age-based protocol with the dose varying from 500 to 2000. Here it is daily 3 consecutive doses of IM that is being given, and the stimulated value is analyzed 24 hours after the last dose. So the results were the median age is 1.75, and we found that almost 80% of the study population fell under the age group of 6 months to 9 years. The data on stretch penile length, testicular size, external genitalia score were also described, and D by THT ratio in suspected 46XY-DST cases. And also the distribution of the external genitalia phenotype among our study participants were also discussed. It includes people group with micropenis, proximal hypospadias, combination of both, cryptorchidism, both unilateral and bilateral, and apparent female genitalia, which constituted majority of the population. So the primary outcome is the following post single dose HCG, the stimulated testosterone was almost 167 nanogram per deciliter, which showed a significant 24-fold of increment from the basal value. And the same has been described based on the external genitalia phenotype 2, and we found that there is a 44-fold increment in the group with bilateral cryptorchidism and least with the micropenis group and unilateral cryptorchidism. And coming to secondary outcome, the stimulated testosterone values, when analyzed between two groups, there was a minimum increment that was seen in the age group beyond 9 years. So the possible explanation of the minimal increment in these groups is because of the higher prevalence of the hypogonadism cases that we had in them. So the comparison of single versus 3-day test, which is done only in the 19 patients, the time interval from the single dose to 3-day varied from almost from 2 weeks to 1 month, which is again a drawback of a retrospective nature of the study. However, on analysis, we found that 3-day HCG test had a minimal increment when compared to single dose, and it is a significant difference. But however, when we analyze this based on the testosterone response with respect to the value of 110 nanogram per deciliter, we found that still 16 of 19 children had suboptimal response to 3-day also. However, the significance is because of all the 16 children showed some increment when compared to single dose, and that explains the significance here. The final diagnosis were not available in all the patients. Only 5 had molecular diagnosis data, and the biochemical parameters like ratios and post-GnRH results were used to arrive at the clinical diagnosis. So, of the 16 cases who had suboptimal response to both tests, the 14 had hypogonadism contributed to 2 molecular cases, 4 due to gonadal dysgenesis and 8 because of hypogonadotropic hypogonadism. So the 2 genetic mutations were MALT1 mutation and IL1RD heterozygous mutation. In addition, the 5-alpha reductase, both genetically and also based on ratio, they showed adequate testosterone response. So I just want to give an idea about the single dose test which had been in practice. The dosage of 5,000 international unit per 1.7 meter square are the various dosages that were used. And recently recombinant HCG is also being tested, and equal results have been found. So our results were also consistent with a few studies which had also incorporated multi-dose protocols. So coming with the studies which had compared single versus 3-day HCG similar to us, the dosage were used a little different. It is 5,000 unit per 1.7 meter square versus 1,500 for 3 days. So similar to our study, the first study, Kaushansky et al., he had analyzed 25 pubertal age group, and he has tested both protocols with 1 month interval between them, and he found that the 3-day is much better than the single dose. But however, the later studies had shown that both the protocols doesn't have statistical significance, and both are almost equal in predicting the Leydig cell activity. So be it a single dose or a multiple dose, the maximum testosterone values are usually seen 72 to 120 hours following the first injection, and the subsequent injection usually do not affect the response for at least minimum of 3 to 5 days. So coming to the limitations of our study, it's basically a retrospective observational, non-availability of molecular diagnosis in all the cases too, and use of a chemiluminescence assay which could be less accurate when compared to the mass spectrometry, and a small sample size. So with this, I would like to conclude that a single dose HCG stimulation test is useful in assessing the Leydig cell activity, and it can be an alternative to 3-day HCG test in the initial evaluation of hypogonadism, with the added benefit of avoiding repeated injections, hospital visits, and school absenteeism. Thank you.
Thank you for this very practical study. It is open for comments and
Yes.
question. Let Dr. Subroto and then Dr. Sanjay.
When you did the 1-day stimulation, did you draw the blood the next day or you waited for a few days?
No, sir. 72 hours post single dose of injection.
After 3 days.
After 3 days.
After 3 days.
Yes,
So actually in both the studies, you took the blood sample in the 3-day, you're supposed to take it on the 4th day. Here you took it on the 3rd day, the 1-day stimulation.
Yeah, in the 3 days, it is usually 24 hours after the last dose, sir, which is again the day 4. So here it is day 3, yes, sir.
Yeah, I just wanted to make that because it takes that much time for the peak effect, and sometimes that comparator is very important to keep in mind. But otherwise, very nice study, very informative. Thank you.
Thank you, Dr. Subroto. Dr. Sanjay.
You administered HCG IM. Can it have any different effect if you use it subcutaneous or IV? Will it make any difference?
Subcutaneous can be given, but I'm not very sure about the changes in the results, sir. But I think it should be as similar as the IM.
I think subcutaneous or IM both can be given.
Just 1 minute.
Yeah.
I think the protocol is IM must be, it is because of the better absorption, because subcutaneous will take longer, and therefore for standardization it is better to use one single route, that is IM, with which you will get a better absorption and better results.
Okay.
So therefore, because IV of course will not use, and subcutaneous will not have much meaning.
I think subcutaneous or IM too, both are recommended.
No. The
IM
Only IM.
She has used IM, and see, even if you see physiologically also IM, it is IM which has to get absorbed.
Okay, thank you.
Okay, so we comes on to the last presentation by Dr. Siddhanath Sudhanshu. So thank you. He is going to talk on vitamin D replenishment and its effectiveness on bone health in children receiving anti-epileptic drug and RCT.
Good afternoon. I'm sorry for my bad throat today. So my study is on vitamin D replenishment and its effectiveness on bone health in children receiving anti-epileptic drugs, a randomized controlled trial. So the background in brief. So it's well reported in the literature that anti-epileptic drugs cause vitamin D deficiency or insufficiency in majority of the patients. And some studies from India, how they are limited, but they have given supportive evidence regarding this. And we all know that the lack of vitamin D supplementation in children may cause serious adverse effects on the bone health. So it is very rational to monitor vitamin D status in such children receiving anti-epileptic drugs and to replenish it if needed. But the thing is that how to replenish it, in what doses? So for that we have a lack of clarity on this, because the American Academy of Pediatrics and the Eastern Pediatric Epilepsy Network UK-NHS, they recommend a uniform 400 IU per day. But the Endocrine Society, they recommend a higher dose of 1200 to 1800 IU per day. And the global consensus recommendation, they refrain from making any guidelines on this. Hence, for this lack of data, we undertook this study to generate some data regarding this, with the objective first to detect vitamin D insufficiency in such children, and then to determine the effectiveness of two internationally accepted vitamin D doses. Those are 1200 and 400 on vitamin D status and bone health by analyzing the changes in serum 25-OHD and the other bone health markers like serum calcium, phosphorus, ALP, intact PTH, P1NP, that is procollagen type 1 N-terminal propeptide, which is a bone marker of bone formation, and a beta cross lapse, that is mainly a marker of bone resorption over a period of 3 months. So in this RCT, we recruited childhood epilepsy subjects receiving anti-epileptic drugs for more than 6 months, and over a period of 1.5 years, we excluded the patients who were non-ambulatory and with chronic systemic disease or receiving drugs which can affect vitamin D status as well as bone health. The estimated sample size for the RCT was 56. It was an intramurally funded project at SGPG-AMS. So for the study plan, we recruited the patients, subjects at the baseline and recorded all the baseline characteristics in the case pro forma and did baseline investigations including 25-hydroxyvitamin D. The children with vitamin D insufficiency, we were recruited under the RCT across 2 arms. And then the vitamin D replenishment was given in 2 oral doses across the 2 RCTs, 1200 IU in group 1 and 400 IU in group 2, along with 500 mg of elemental calcium per day for a period of 3 months. And the vital biochemical markers for vitamin D status and bone health were done as explained earlier and as it's mentioned below at the beginning and at the 3 months. And additionally at 3 months, we did 24-hour urinary calcium creatinine ratio to look for any evidence of vitamin D toxicity. Now coming to results. At the baseline, we had 70 patients, and the salient features findings were that majority were on polytherapy, and 86%, 60 out of 70 had vitamin D insufficiency. And the group of children who had vitamin D insufficiency had significantly elevated ALP and PTH as expected. Now coming to the RCT part, so out of 60 patients who were vitamin D insufficient and recruited under the RCT, 10 lost to follow-up, and we had 50 patients, 24 in group 1 and 26 in group 2. And we did a per protocol analysis. At baseline, both these groups were comparable. Now at 3 months of follow-up under this RCT, so the percentage of vitamin D, we can see that in group 1, all the patients achieved the status of vitamin D sufficiency in comparison to 70% of the patients in group 2. And the 25-OHD level was significantly higher in group 1 in comparison to group 2. And the other markers of bone health like intact PTH, ALP, and beta cross lapse, they were significantly better in group 1 receiving the higher doses in comparison to group 2. And the changes over the 3 months in these parameters were also significantly better in group 1 in comparison to group 2. However, the changes in serum calcium, phosphorus, and P1NP was not significantly different between these 2 groups. And the intervention was safe as none of the children developed toxic levels of vitamin D or developed hypercalciuria or hypercalcemia. Now coming to the discussion part, so we needed some research on this to generate some data. As some studies have shown that some meager amount of vitamin D in children receiving anti-epileptic drugs, they don't make them vitamin D sufficient. And over a period, it can lead to decline in bone health, including the bone mineral density. So we found a similar proportion of subjects becoming vitamin D deficient, and this effect of vitamin D deficiency was reflected by significantly higher PTH and ALP in these children, and 3 children had such high ALP and PTH signifying biochemical rickets. So in our RCT, we showed that the group 1 who received 1200 IU per day, they had a much better vitamin D levels and the vitamin D sufficiency status, as well as the bone health markers comparison to the group 2 at 3 months, and even the change over the 3 months was significantly better in group 1. So there is no much data on like such direct comparison, but some researchers, including the Mikati et al., in his RCT, he showed the effect of a low dose of 400 IU per day versus a high dose of 2000 IU per day, its effect on BMD. And he showed that though both had significant improvement in BMD, but the subjects receiving a higher dose, they had a better and more significant improvement, and towards a better improvement in the BMD. So this trial was safe, and none of the children developed the evidence of vitamin D toxicity and or hypercalciuria or hypercalcemia. So limitations were small sample size and the smaller duration of follow-up, because the P1NP, we think if it would have been, it's a marker of bone formation, so it may show up the significant difference if the follow-up was of the higher duration. And also a study including BMD, changing in BMD would have been much useful, but we could not do that. But the conclusion of our study was that this higher vitamin D doses is safe as well as effective in having a vitamin D sufficiency status and the better bone health markers. So the message is all the children on AED, they need to be evaluated for the vitamin D status, and it should be replenished as needed. And a higher dose of vitamin D, 1200 IU, is safe as well as very effective. But further research is needed in this regard, including the longer duration and the inclusion of BMD. Thank you.
Thank you, Dr. Sidnath. Two quick questions from my side. I was interested in knowing what were the anticonvulsants which were being used, because the earlier ones were more commonly associated with these alteration with the
Yes, ma'am,
calcium
yes.
metabolism, but the latest ones are not.
Yes, ma'am.
And
So-
overall, we also know that over a period of time, we are actually showing marked hypovitaminosis D in the general population. So just to put them together, I just wanted your
among
answer.
the AED, we categorize them in enzyme inducer and non-enzyme inducer.
Huh.
So enzyme inducers like phenobarbital, carbamazepine, they are known to cause vitamin D
So
deficiency.
which ones did you take?
So
Or you
our
took both?
patients, 86% were on the polytherapy. So we are taking both enzyme inducers as well as
Okay.
non-inducers, including valproate and levetiracetam.
Okay.
So for valproate, we have evidence that they also cause vitamin D insufficiency. For levetiracetam, we don't have consistent reports on this.
I do not know whether it is because of the valproate, because the general population is relatively low.
It
And
could
we
be,
are
ma'am.
we are working in the
Yeah.
current times. Times have changed.
So I didn't show
that
the
is all.
data,
So
but the
I just open it for a question from Dr. Rajesh Khadgawat. Oh, sorry. Yeah.
I had almost the same question. I think you need a breakdown of the anti-epileptic drugs that you are using, because if you have more drugs in a group, in a certain group that will catabolize vitamin D more rapidly, then you would get this difference.
Yeah. So in our study, 86% of the patients were on polytherapy who were receiving both.
But you need a breakdown of the drugs that you
data
are
I
using.
didn't show, but the basic baseline vitamin D status was not different between the group using polytherapy.
I don't think that counts, because you need a breakdown.
Right.
Final comment by Dr. Khadgawat, sir.
Well-planned study. My first concern is regarding compliance, how ensured compliance, because it's a 3-month study and they have to take daily vitamin D. And second thing related to your vitamin D. your center previously has reported huge prevalence of vitamin D deficiency from that area, and these are the diseased children visiting hospital, so more likely to have vitamin D deficiency. But 86% of your patients had more than 20 nanogram per ml, which is not deficiency, which is insufficiency.
Yes, sir. Insufficiency.
Insufficiency.
Yeah, right, sir.
But overall prevalence reported all over from our country, from your center, from SGPGI, multiple studies reporting 90% vitamin D deficiency, not insufficiency. So concern is, are they taking vitamin D before coming to the study? Because levels are looks little bit very good.
Yes, sir. Right, sir. You are absolutely right, because we had to exclude many patients because they were receiving some amount of vitamin D, and the common practices of giving that weekly vitamin D and repeating that cycle over and over again. So we had put a criteria that in last 6 months they have not received any stock dose, like 6 weekly dose or monthly dose, but still they might be taking because they were coming to a referred center and might have received something. So the 3 months period, at that point of time, they were monitored. We used to call them actually. So with that, we try to ensure the compliance. But yes, I can understand that there could be lapses in the compliance.
Thank you, Dr. Siddhanath. I think it's a wonderful discussion, and we are thankful to all the presenters, and definitely on the last day, the audience that is sitting here and interacting. Thank you very much.
I thank all the
Thank you,
speakers.
and we will be moving fast downstairs
I
also
just
for the
request
next
Dr.
session.
Subruti Day to kindly felicitate our esteemed chairpersons. Madam.